Well, let's start. Thank you everyone for joining us for the Yale Department of Radiology Grand Rounds today. I am delighted to introduce to you Dr. Anna Franceschi, who is an associate professor at the Donald and Barbara Zucker School of Medicine at Hofstra Northwell Health. She completed fellowships in neuroradiology and PET MRI at the New York University School of Medicine. She is one of the leading researchers in brain PET MR hybrid imaging with focus on dementia and neurodegenerative disease. She has recently completed a book on applications of PET MRI in neuroimaging and is the recipient of the American Society of Neuroradiology's highly selective 2021 Berger Research Award for the study of Alzheimer's disease and neurocognitive disorders. Thank you, Dr. Franceschi, for joining us and for sharing your expertise with us.
Thank you so much for having me. It's such a pleasure to be here. And I actually still very fondly remember my residency interview at Yale, which was actually just about 10 years ago. So it's wonderful to be back, even virtually, and hopefully sometime soon in person as well. So let me share my slides. There we go. Okay, so as Mariam was kind enough to say, I'll be talking to you a little bit about my experience with some novel PET MRI biomarkers and with a special focus and emphasis how they can be applied to dementia therapeutics. So these are my current disclosures. So just a little bit of background as an introduction, as I'm sure everyone here is well aware, historically, both the diagnosis and also treatment of various types of neurodegenerative disorders have been hampered by the lack of non-invasive biomarkers of underlying neuropathology. And, there are some numbers I like to highlight, and some of the most striking ones include that, for example, up to a third of patients clinically diagnosed with Alzheimer's actually lack AD-type pathology at autopsy. And also in the community setting, in clinical practice, it's been reported that physicians may not recognize about a third of patients with mild dementia signs and symptoms. And finally, perhaps most strikingly, it is currently the only cause of death in the top 10 in the US that really does not have any effective treatment or, quite frankly, really effective preventative measures. So this all highlights the urgent need to find methods of early detection and then subsequently effective dementia therapeutics. In fact, by 2050, there will be about 14 million people living with Alzheimer's. And prior to COVID, I always used to say that this is our next pandemic. And I think you will see in coming years that it truly is. The overall cost, actually, when you include medical care, loss of productivity, caregiver time, is projected to hit $2 trillion by 2030. And meanwhile, clinical drugs trials still have over 90% failure rate. In fact, if you exclude memantine, which was the last FDA-approved agent back in 2003, they essentially have 100% failure rate. And this is not only recognized in the clinical or in the pharma setting, the scientific community has also recognized that. And for example, when you look at NIH awards awarded to radiology departments, 2015 was actually the year when funding strongly shifted to the neuro spectrum. And for example, most common spending categories included neurosciences, brain disorders, prevention, and aging. And from our end, from an imaging perspective, there's a need to find accurate molecular imaging biomarkers. And the key goal, or the first goal, I would say, is to effectively separate patients with underlying AD-type pathology from other neurodegenerative disorders. And this will allow us, firstly, to identify individuals who are at risk for AD, but also test various disease-modifying drug targets. Primarily, or at least in the past, as we'll see on towards the end of the presentation, these target extracellular neuritic plaques, which are composed of beta amyloid aggregates, and then intracellular neurofibrillary tangles, which are formed by the hyperphosphorylated tau protein, which together make the histopathological hallmarks of Alzheimer's disease. Now, this leads me to bring up the ATN classification, which was developed by Clifford Jack at Mayo back in 2016. And it really underlines our shift from a clinical and phenotypical to a biological definition of Alzheimer's disease, as it emerges in the research setting, but then also firmly is slowly translating into clinical practice as well. And the ATN stand for A for amyloid, CSF or PET, T for tau, CSF or PET biomarkers, and then N for neurodegeneration, which can be imaged by FDG PET as a marker of neuronal injury and synaptic dysfunction, and also by volumetric MRI as a direct measure of underlying neurodegeneration. Now, when we talk about simultaneous PET MRI, and actually I was very excited to hear that you will soon have one available for clinical use at Yale as well, they really do offer a very exciting possibility since they allow us to combine metabolic markers with receptor binding, perfusion, and neurotransmitter release data. And why is that important, or why is that relevant? First of all, it will allow us to effectively study target engagement in clinical trials. In terms of current help for patients and their families, it really will allow us to guide appropriate social interventions, including future planning, and then initiate the neuroprotective strategies that we can offer to our patients at this time. And what we do with a hybrid PET MRI scan, we essentially combine lobar-specific patterns of atrophy on volumetric MRI with patterns of neuronal dysfunction on FDG PET, and then results from amyloid, tau, and some other novel molecular imaging biomarkers, which allow us to come to an accurate pre-mortem diagnosis of the underlying neurodegenerative process. And this kind of brings me to the first tracer that we will discuss a little bit, and that's amyloid imaging, amyloid and amyloid PET imaging. So when we think about amyloid PET, it's important to know that we have actually 3 FDA-approved radio tracers of the total 6 that are approved for neuro-related neuroscientific disorders. And the 3 are florbetapier, flutemetamol, and florbetaben. All 3 are used in the US. I personally have experience with Amyvid and with Neuraseq, and they're quite comparable. They have about greater than 90% sensitivity and specificity for detection of increased cortical amyloid burden. So a couple of things are important to keep in mind. First of all, when we have a positive scan, it does not necessarily mean that the patient has Alzheimer's, but it's a fantastic exam of negative predictive value, or an exam of exclusion. So essentially, if the amyloid PET is negative, the patient's cognitive impairment is due to something else and not Alzheimer's. And in at-risk subjects, a positive amyloid scan is associated with the 3 times greater risk of eventual progression to dementia. Now, when I look at these studies in clinical practice, I like to think of them as very binary, like a 0, a negative scan, or a 1, a positive scan, without really too much qualitative analysis or qualification. So as you can see on the negative example in the top 2 rows, we have in a normal individual, cognitively normal subject, we have tracer uptake in the white matter. And then that's our 0. When we look at the bottom 2 rows in the positive individual, we have uptake in both the white and the gray matter. And this scan essentially is positive, implying that the patient has increased cortical amyloid burden. One important thing to keep in mind, or the most significant limitation, is that an positive amyloid PET by itself is insufficient for a definitive diagnosis of AD. Now, you can't really talk about amyloid PET with at least touching base on the IDEAS study, or the Imaging Dementia Evidence for Amyloid Scanning study, which was a large-scale trial that enrolled about 16,000 people across the US and assessed clinical usefulness and, perhaps more importantly, impact on patient-oriented outcomes of an amyloid PET scan on patients with MCI and dementia of uncertain etiology. There's renewed excitement about amyloid PET since the new IDEAS, or IDEAS 2 study, was launched by the ACR last fall. and it's projected to run, or it's scheduled to run until 2024 with same aims and include a racially diverse cohort and bank DNA and plasma. At Northwell, we are actually getting ready to start scanning our first patients shortly and are quite excited by this. The initial IDEA study addressed two specific aims. The first aim was the impact of amyloid PET on patient management at 90 days. And the results were, extraordinary. So first of all, there was a reported change in medical management in nearly 2/3 of patients. And even more strikingly, there was a change in diagnosis in about 1/3 of subjects. So from AD to non-AD dementia and vice versa, in 1/3. The second aim was the impact of amyloid PET over a year on subsequent major medical outcomes. And the measure they really most focused on was patient hospitalizations. And that didn't change as much. The patients who had an amyloid PET had only about 5% fewer hospitalizations in the next year than unscanned matched participants. So that kind of still leaves open the question if the benefits of scanning would be worth the cost as far as CMS is concerned, and we're still waiting on some new decisions as far as that goes. Now, I have one example. This is a Amyloid PET MRI, and you see the 3D T1MP range on the left, the amyloid PET image in the center, and then the fused image to the right. And just this is a positive study. As you can see, there's uptake in both the gray and the white matter. And one just little bit of information to remember is that when you look at the recommendations from all three of the tracer manufacturers, these studies actually are meant to be interpreted in black and white mode. So unlike all of the pretty color images that you see in research publications, clinically, we're supposed to be looking at them kind of like the central image, so purely in black and white. When we talk about the spreading pattern of an amyloid pathology as the disease, as Alzheimer's disease progresses, we typically talk about a downward spreading pattern. So initially, we have diffuse accumulation in the neocortex, so in the frontotemporal and parietal association cortices, and then it slowly goes inferiorly into the subcortical structures, the basal ganglia and the thalami, and then into the brainstem and cerebellum. And again, from the seminal JAMA paper in 2011, you see top row a negative amyloid PET with uptake only in the white matter, and similarly immunohistochemistry of the precuneus that is not staining for beta amyloid. And then as you see subsequent mild and then advanced AD, we see tracer uptake in both the white and the gray matter and markedly positive immunohistochemistry to go along as well. Now, one of the amyloid targeting agents that I just want to bring up briefly is Biogen's aducanumab, which is a monoclonal antibody against amyloid beta. And the reason I'm highlighting this specific drug is that it's actually undergoing BLA review with the FDA right now. So it was quite the drama, since initially their phase 3 clinical trials emerged and engaged were paused back in 2019 because they missed, or they were reported to miss their primary endpoints, and it was charted as another failure of amyloid targeting agents. However, about half a year later, they came back and said actually their interim futility analysis was wrong, and we think we have something there. So they did apply for BLA last summer. There was again a little bit of a hiccup in this road, since the FDA advisory committee had a negative vote back this fall. And so now the new PDUFA date is actually in less than a month, on June 7th. So all of us in the dementia community are extremely excited to see what happens. And one of the reasons is that, as I said initially, there hasn't been a new drug on the market since 2003, so almost in 20 years. And perhaps most importantly, if approved, this will be the first disease-modifying drug for a dementia indication. And with that, we'll slowly shift our attention to tau PET imaging and tau accumulation in AD. So as far as tau, after all of this talk about amyloid, the question is, why tau now? What are the benefits, or what's the difference? So firstly, Postmortem studies have indicated that the severity of neurodegeneration demonstrates a far better correlation with neurofibrillary tangle as opposed to beta amyloid plaque load. And more importantly, similarly to FDG, when you have a tau PET scan, there's a very close association with clinical severity and neurodegeneration, and it actually allows us for disease staging. So as you will see, actually, let me pull up the next slide. There is this stepwise progression of tau pathology in the Alzheimer's brain that follows closely the Braak histopathological stages. So as you see on the left-hand side, initially we have a tau uptake only in the transentorhinal cortex, which correlates to Braak stages 1 and 2. Then we move on into the limbic phase, which spreads in the temporal cortex and slowly towards the precuneus and association cortices, corresponding to Braak stages 3 and 4. And then finally, we come to the isocortical stage of Braak 5 and 6. Now, as far as the radio tracers available, there's been a lot of events in this field as well. So AB 1451 or fluortaucipir back in last May, so in the height of the pandemic in May 2020, the FDA approved fluortaucipir as the first agent to image tau pathology in vivo using PET scanning, and its trade name is Tauvid. Looking at the fluortaucipir data, there's a 4 to 8 times higher level of phosphorylated tau protein in the Alzheimer's brain compared to age-matched healthy controls. And as I mentioned before, the location and also the magnitude of tau accumulation on PET scan appropriately predicts future brain atrophy and neurodegeneration. And in addition, tau uptake in disease-specific brain regions is associated with decreased cognitive performance. Now, one of the early examples from the literature, in the top row, we have a negative fluortaucipir PET scan, and you see there really isn't any significant binding. Looking on the coronal image on the right-hand side, you see some off-target uptake in the subcortical structures, and we'll touch base upon that because that has been one of the limitations of first-generation tau tracers. And then the bottom row, we have a patient with an MMSE score of 22 and a clearly abnormal scan with uptake in the mesial temporal regions that's best appreciated on coronal view. And then when you look at sagittal, you see uptake in the precuneus and posterior cingulate gyrus, key areas that are always involved in AD, and eventually spreading into the frontal regions, indicating advanced disease. Now, when we talk about the emerging role of PET tau pathology, so there are a couple of key things that tau PET MRI can provide. Firstly, prediction of progression to Alzheimer's disease in asymptomatic patients or those with MCI. Then secondly, as we now saw, disease severity and more importantly, disease staging. And then finally, selecting patients for tau targeting, disease modifying clinical trials, and of course, monitoring outcomes and effectiveness of such medications. This is one of my own examples. If you hone in on the, well, it's actually zoomed in, so you have to, whether you like it or not, if you take a look at the mesial temporal structures, so we see increased uptake. The area that we focused on included the entorhinal cortex, the amygdala in the inferior temporal gyrus, and we used SUVs greater than 1.25 to denote a scan that a so-called high PET tau scan, and the reference region in tau PET, similarly to amyloid PET imaging, is the cerebellum, unlike FDG, where we typically use the whole brain or brainstem. Now, this is just the FDA approval press releases. And one thing I like to highlight when we talk about this is, as we said at the beginning of the talk, the neuropathological diagnosis of Alzheimer's requires the presence of both beta amyloid neuritic plaques and tau neurofibrillary tangles in the brain. And as of essentially last year, we have PET agents that allow us to make an accurate and kind of final, quote unquote, final diagnosis of AD antemortem. This is from the PET to autopsy validation study that was used as the basis of the FDA application. And we can see, again, in the top row, a negative tau PET with some off-target binding, and similarly, lack of neurofibrillary tangles or amyloid pathology on histopathology. Similarly, moderate uptake with uptake only in the mesial temporal regions and the limbic association areas. And finally, the advanced AD patient that has disease clearly in the isocortical areas and even spreading specifically to the frontal lobes, indicating an advanced neurodegenerative process. Now, in terms of future trends in tau, again, selective tau PET will allow us to examine tau accumulation over time and correlate it with cognitive function for disease staging. The presence of tau deposition in beta amyloid positive patients allow us to establish a definitive diagnosis of AD antemortem. And finally, measuring and monitoring tau load will support the development of tau targeting disease modifying therapies. Now, I did mention that there are some limits to the first generation tracers. And as I play this video here, this is a PET MRI, so a 3D T1 MP-RAGE MRI sequence fused with a floor tau superior PET in a positive patient. But what you will notice, and what I want to actually for you to pay attention to in this slide, is the off-target binding. And if you can take a look here, you see the basal ganglia and the thalamus uptake. You see uptake in the choroid plexus. You also see uptake in the midbrain. And one of the key limitations, or one of the key issues that was recognized early on, is that the uptake in the choroid plexus, especially the uptake in the choroid plexus in the temporal horns, can quite often be misunderstood or misinterpreted, I should say, as uptake in the adjacent hippocampal formation and entorhinal cortex, leading to potentially false positive interpretations. And also, I should say, there's also oftentimes mentioned off-target binding to monoamine oxidase and some other regions in the brain. So that brings us to kind of next steps in tau PET imaging. And when we think about that, we talk about the second generation tracers that are in development and that are being used actively in research settings, but not yet FDA approved. The one that I have experience with is PI 2620. And here's an example from the literature. The top row is a floor beta band amyloid PET scan, which is clearly positive with tracer uptake in the cortical gray matter. And then in the bottom row, you see a positive PI 2620 tau scan. And you see, again, kind of very similar biodistribution to floor tau superior, mesial temporal regions, precuneus posterior cingulate, and then spreading into the frontal lobes in advanced disease, again, following the Braak stages quite well. But if you kind of zone in on the coronal or axial views, this time you don't see any off-target binding in the choroid plexus. You see almost no uptake in the subcortical structures. So these are some of the benefits of the second generation tau tracers. And again, a little more examples, just to kind of prove my point. But again, nearly absent off-target binding to monoamine oxidase, subcortical structures, and choroid plexus. Now, another benefit of the second generation tracers that we like to mention and we like to discuss is that floor tau superior is very selective for 3R, 4R tau, and that's great for Alzheimer's disease because that's the underlying tau isoform accumulating in AD. But actually, other types of neurodegenerative diseases or other tauopathies have other types of tau. So, for example, patients with Pick's disease, a type of frontotemporal dementia, typically have 3R tau accumulation. Meanwhile, patients with some of the atypical Parkinsonian syndromes, such as PSP and CBD, and also patients with agrammatic primary progressive aphasia have 4R tau and are not well imaged with floor tau superior. So in this example, the fourth row is the classic AD pattern that we discussed. But when you look at the top two rows and you see this prominent uptake in the subcortical structures in the midbrain, also in the dentate nuclei of the cerebellum, these top two rows are examples of patients with progressive supranuclear palsy. And the PI 2620 tau uptake that you see corresponds well to areas that are pathologically involved in PSP. So these second generation tau tracers may allow us to appropriately image other tauopathies as well. And with that, we will now move on to biomarkers or PET biomarkers of neuroinflammation. So now, as far as neuroinflammation, there's long been evidence that the brain undergoes so-called inflammaging as a person kind of ages, progressively acquiring a pro-inflammatory environment. And this inflammaging actually contributes to the age-related risk of sporadic neurodegeneration. There are several types of PET tracers looking to image neuroinflammation, and the best developed groups are the ones focused on translocator protein, or TSPO. So oftentimes we'll talk about TSPO PET imaging. And TSPO essentially is a protein which is found on the outer mitochondrial membrane of microglia and astrocytes. And it's interesting for us since it's minimally expressed in the healthy brain parenchyma, but is markedly upregulated in the presence of neuroinflammation and is therefore a tissue-specific biomarker of brain inflammation. So now when you think about it, there's a lot of potential pros to image patients with TSPO PET. There was a significant overlap between activated microglia, pro-inflammatory cytokines, and TSPO binding in early animal studies of neurodegeneration. Once this was, shifted to clinical human studies, increased TSPO PET signal was demonstrated in disease-relevant areas in Alzheimer's, but also a wide spectrum of neurodegenerative and neurocognitive disorders. And taken together, this data supports the use of TSPO PET, most importantly as an imaging biomarker to monitor target engagement and treatment response in trials of anti-inflammatory dementia disease-modifying drugs. And as you see on this image here, one of the early carbon-11 first-generation TSPO PET tracers, you see markedly increased tracer uptake in the patient with Alzheimer's disease as compared to the age-matched healthy control. However, there are some certain challenges. One of the most important ones is that there is relatively low brain penetrance and also high nonspecific binding, which results in poor signal-to-noise ratio. This has been worked on with second and now third generation TSPO PET tracers. But the other major problem is that interpretation of these scans is markedly limited by the existence of 3 binding affinities, so-called low, high, and mixed affinity binders, and this leads to inter-individual variability in PET signal. And essentially for each patient and for each trial, this necessitates stratification of patients by genotype. So what I mean by that is, this is an example of distribution volumes of FEPA, second generation TSPO PET tracer, and top row is a patient that's a mixed affinity binder. Bottom row is a patient, or I should say a subject that's a high affinity binder. And essentially the only difference in the magnitude of signal here is the patient's underlying genotype rather than actual neurodegenerative disease. And again, you can clearly from this example, recognize how important this stratification by genotype is. And again, how costly it is to run an effective trial using TSPO PET as a biomarker. I did have a small study looking at neuroinflammation in World Trade Center responders with cognitive impairment. And what we found was there were sort of as expected, increased distribution volume values in responders with cognitive impairment compared to matched controls. And actually similarly that there was increased binding in patients that had PTSD re-experiencing symptoms. And in these cases, specifically increased uptake in the parietal and occipital regions. And this was, of course, needless to say, after we adjusted for genotype. So looking at the violin plot on the left-hand side, you see increased FEPA binding in the responders with mild cognitive impairment. And similarly on the graph on the right-hand side, we see increased distribution volumes in patients that had PTSD re-experiencing symptoms. All right, so our next topic will be cholinergic PET tracers and the cholinergic hypothesis of geriatric memory dysfunction. And I kind of like to think of this as back to the basics. So, back in the 1980s, there was this cholinergic hypothesis of geriatric memory dysfunction developed, which assumed that cognitive decline is primarily caused by reduction of acetylcholine in synaptic clefts as a consequence of reduction of nicotinic neurons. And this came about since early data revealed that there is a significant reduction in actually various compartments of cholinergic neurotransmission in patients with Alzheimer's, dementia with Lewy body, and Parkinson's. And when this was studied a little bit closer, apart from a nicotinic acetylcholine receptor deficiency, postmortem data also revealed reductions in vesicular acetylcholine transporter and also in acetylcholine esterase activity in AD. The other important point to keep in mind is that cholinergic cell death occurs quite early in the pathophysiology of Alzheimer's, and it also strongly correlates with disease severity, again, bringing up the possibility of disease staging. And this has certainly led to a recent development of novel, both presynaptic and postsynaptic cholinergic PET tracers. Another important kind of caveat or another important reason for developing cholinergic PET imaging is when you look at this table of the 5 currently FDA approved medications for Alzheimer's disease, 4 of them are at least in part acetylcholine esterase inhibitors. So having an appropriate cholinergic PET biomarker will allow us to understand the relative lack of effectiveness of current procholinergic drugs that are FDA approved, and hopefully facilitate development of the next generation of cholinergic targeting dementia therapeutics. The tracer that I have had some limited experience with is VAT-PET. It's a PET biomarker that allows for visualization and it binds to the vesicular acetylcholine transporter. As you see from this example, compared to the elderly healthy control, the patient with cognitive impairment has markedly decreased tracer binding in the entorhinal cortex, amygdala, and also in the cingulate cortex, which essentially implies lower density of the vesicular acetylcholine transporter in these patients. So the benefits of VAT-PET MRI is essentially that they may serve as a sensitive and reliable characterization of presynaptic cholinergic nerve terminals. And early research has demonstrated that there are major reductions in VAT-PET uptake in key areas involved in Alzheimer's, including specifically in the temporoparietal cortices and the posterior cingulate gyrus. And when compared to cognitive performance, both MoCA and MMSE scores are correlated with both FDG binding, but also VAT-PET binding, or decreased binding, I should say, as well. And in one study, these scans were more sensitive than either FDG or amyloid to appropriately distinguish AD patients from controls. So when you look at the imaging example here on the right-hand side, top row is a cognitively normal individual, and you have the VAT-PET, FDG PET, and amyloid PET respectively. And then bottom row in the patient with Alzheimer's disease, you see that there is significant decreased uptake on both the VAT and the FDG PETs. And again, in both tracers, we have decreased binding in the precuneus and posterior cingulate gyrus, which are areas that are known to be involved very early in AD. And of course, similarly increased expected binding on the amyloid PET as well. And again, because of this correlation with disease progression and severity, these cholinergic tracers may allow us to quantify disease severity and then allow for disease staging. So again, here is our example and kind of the nice graph of correlation between MoCA and binding in the entorhinal cortex. And this kind of underlines the potential of VAT-PET to serve as a cholinergic biomarker of treatment response in disease-modifying drug trials. And again, key points, studying target engagement of the procholinergic drugs, and then hopefully facilitate development of more effective next generation cholinergic targeting dementia therapeutics. And now just a little bit, or the next kind of little segment will be on ABDO PET and ABDO as a biomarker of nigrostriatal degeneration. I'm especially excited to talk about ABDO because as you see here from the BLA application with the FDA, it was developed at Northwell at the Feinstein Institutes for Medical Research. So it's always kind of been our baby. It was actually approved back in October 2019 after over a decade of work on this, but unfortunately it's still not reimbursed by CMS, and so we scan these minimally for at least for now in clinical practice. Just one kind of side note on this, my dad always says that Europe and Australia are 10 years ahead of the US in terms of molecular imaging and certain PET tracers, and I always dismiss those claims, but as you can see, ABDO was actually approved in France in 2010. So here we are. So as far as ABDO PET, it's a PET tracer which crosses the blood-brain barrier. It's converted to fluorodopamine in the striatum, and it's actually stored in the vesicles of striatal terminals of dopaminergic neurons, and it allows us to appropriately assess presynaptic dopaminergic activity. These scans are abnormal in patients with idiopathic Parkinson's disease, but also in patients with atypical Parkinsonian syndromes such as PSP, MSA, and CBD. And this is clinically relevant since it allows us to distinguish between Parkinson's disease and Parkinsonian syndromes in patients with Parkinsonism, which is not due to underlying neurodegeneration. And this, of course, leads to important differences in patient management. This is an example of ABDO PET as the disease progresses from one of our early scans at Feinstein. And we see the normal example where we have robust tracer binding in the striatum. And then as the disease progresses, we have loss of uptake first in the putamen. And then once we get to severe disease, also in the caudate nuclei. Typically, we can quantify these results by using the striatal occipital ratio. And in these scans, our reference regions is typically the occipital cortex, the occipital lobes. ABDO PET has 100% sensitivity and specificity in patients with early Parkinson's disease. It is quite comparable, although it has underlying different binding targets to the efficacy and the sensitivity and specificity of that scan, but it does provide higher resolution and sensitivity. And as you will see at a subsequent example, it really allows for beautiful separation between the caudate and the putamen, and kind of you see this nice line of the internal capsule. And again, it demonstrates decreased binding, which occurs in parallel with degeneration of the nigrostriatal pathway, and also reduction of the dopamine transporter, which is the target of the SPECT DAT scan. Another interesting thing to point out is that ABDO is actually incredibly similar in structure to levodopa, the medication for Parkinson's disease. And in fact, there's only a single difference, which is the F18 atom instead of the hydrogen at position 6 of the aromatic ring. And kind of this points out all of the potential safety concerns are not merited, since there's been over 40 years of levodopa use with much higher and repeated use. So this was actually quite helpful for our FDA application. And finally, this is the example I promised. This is a negative ABDO scan, and you can see how beautifully you can image the striatum, and on the coronal view on the right-hand side, specifically, distinguish between the caudate and the striatum. And as far as the proposed role of ABDO PET, the idea is that it can serve as an in vivo biomarker of dopaminergic neurodegeneration in patients with idiopathic Parkinson's disease, but also in patients with the atypical Parkinsonian syndromes, and also actually in patients with dementia with Lewy bodies. And this brings me to kind of the last segment of the talk, where I'd just like to talk to you a little bit about Dementia Therapeutics, and specifically the AD drug development pipeline. So if you take a look on clinicaltrials.gov, currently there are 121 unique therapies in clinical trials for Alzheimer's disease. And when you think about it, this is a very small number. Comparatively, there's over 6,800 therapies in clinical trials, for example, in oncology. In fact, there's over 430 medications that are being currently studied for diabetes. So that is quite limiting in many ways. The majority of these drugs are so-called disease-modifying agents. They have various different underlying targets, but currently the most common ones are still amyloid and tau as the primary targets. And these disease-modifying agents are target disease onset or progression and are actually intended to change underlying biology. Of the other 24 agents, there is a number of cognitive enhancing agents and then medication that are meant for treatment of behavioral and neuropsychiatric symptoms. In terms of recent developments, looking at the last 5 years, there's been a progressive emphasis on non-amyloid targets, especially in the context of failures of many of the BACE inhibitors and other amyloid targeting agents. And this includes disease-modifying candidates for neuroinflammation, synapse and neuronal protection, some vascular factors, neurogenesis, and also epigenetic interventions. And then also very interestingly, there's a growing number of repurposed agents. So medications that are already approved by the FDA for a non-AD related indication, and they actually comprise over 40% of the current pipeline. Now, this is a busy slide, essentially demonstrating, the various mechanisms of actions of the 121 agents currently in clinical trials. There's 29 agents in phase 1, 65 in phase 2, and 27 in phase 3. And if you take a peek at phase 3, there's 6 agents. These are the red guys that target amyloid, including Biogen's aducanumab that I mentioned that's currently under BLA review. It's actually the only medication of these that's undergoing BLA review at the moment, and then a single tau target that's also in phase 3. And also I'd like to just discuss, the reasons for the relatively small number of agents that are currently in trials. And one of them is that up until now, or up until recently, and up until this flurry of new molecular imaging biomarkers, the target biology was relatively poorly defined. There was a limited availability of biomarkers. In fact, when you look at numbers across the US, there's fewer than 2,500 PET scanners across the country. Inherent longer trial duration, which of course leads to greater expenses and a very high failure risk, right? We just talked that there's over a 90%, in fact, almost an 100% failure rate if you look at outcomes of trials over the last 20 years. Now, focusing or zoning in on the phase 3 clinical trials, which are kind of closest to making it to clinical practice, about 60% are disease-modifying therapies. And as we saw on the prior slide, 6 targeting amyloid, 1 targeting tau, and then some other target pathways as well. And the interesting thing to highlight, as I mentioned, over the last 5 years, there's been a progressive emphasis on non-amyloid targets. And then when you just compare it to 2019, there's actually a progressive emphasis and an increase on pathways other than both amyloid or tau, which again kind of brings to the relevance of some of these other PET tracers that I've discussed throughout the talk. Looking at where these trials kind of take place, which is always something that I'm very curious about. I was actually really surprised that while the majority are sponsored by biopharma, the number is actually only 46%, and almost 40% are run by academic medical centers, although a lot of the agents studied in academic medical centers are in fact repurposed agents. And then thinking about the number of subjects that are needed to kind of enroll into these trials, there's a total of over 31,000 participants currently in these drug trials, or that's the number of participants required for currently recruiting trials. And what's always been quite interesting to me when you look at phase 2 and then particularly at phase 3, you can see that these are conducted really all over the world. So it's truly a global effort. Now, it's just one last thing is to kind of think about our role as imagers, and in conjunction with these, in relation, I should say, to these clinical trials. This table highlights the biological criteria for trial patient inclusion in the clinical trials, and also the markers that are used for monitoring target engagement and determining trial outcomes. And as you can see, kind of the key biomarkers are, again, CSF, plasma, and PET imaging, amyloid and tau, and also some trials still use FDG PET, and of course volumetric MRI. And again, given that currently 80% of the candidates are in fact disease-modifying drugs, looking at the last 5 years, and especially looking over at the last decade, there's been a progressive integration of imaging biomarkers into development programs. Most recently, it's particularly been the integration of tau PET, which has almost become the norm. And again, these are meant to study target engagement. So just to kind of wrap up, in conclusion, thinking about Alzheimer's disease, also thinking about other types of dementia and neurodegenerative disorders, in the past, and actually not so long ago, we really had a purely clinical phenotypical definition of neurodegenerative disease. So we dealt with, impaired cognitive domains, including impaired speech, impaired motor function, changes in personality, and other processes that we can determine on the basis of clinical exam. And we slowly shift towards a biological definition. And now we are so fortunate that we can actually appropriately image, for example, both beta amyloid and tau PET, also neuronal injury via FDG PET, dopaminergic deficits, cholinergic deficits with the new, fat PET tracers, synaptic density, as well as brain structure via volumetric MRI. But, there's always more work to be done. So the bottom kind of 4 are candidates that we are still working on. So, I would love to have PET tracers binding, for example, alpha-synuclein, TDP-43, FET, and also the mutated Huntington protein. Of these 4, actually, there's a lot of work ongoing on alpha-synuclein agents. And I think that is going to be kind of the next radiopharmaceutical type to enter into, clinical research trials. And then for me personally, I would love an agent targeting TDP-43. And this is kind of an abnormal protein that's found in patients with semantic dementia or semantic variant of primary progressive aphasia, and some other types of FTD. So, this was meant to be an overview of available neuroimaging biomarkers for accurate in vivo evaluation of neurodegenerative diseases and related histopathological hallmarks, which were previously only detectable post-mortem. And, I hope I was able to outline this progressive shift from a phenotypical to a much more biological definition of dementia and neurodegenerative disorders, as it currently emerges in the research settings, but also, slowly but surely translates into clinical practice. And just I would like to leave you with this image of so-called super agers. So this was the Society of Nuclear Medicine and Molecular Imaging 2020 image of the year. And what it shows is, as you can see in the top row, relative resistance to both tau and amyloid pathology in this group of elderly cognitive overachievers that have been dubbed super agers. And, I kind of hope that all of us very firmly fall into this very category as well. So that's all I had for today. And thank you so much. I'd love to take some questions if anyone has any for me.
Thank you so much, Dr. Franceschi. This was a fantastic talk, and I learned a lot. We have a first question in the Q&A. It's by Dr. Darko Pukar from Nuclear Medicine. He says, great talk. Can you define successful Alzheimer's disease trial in terms of outcome variables?
Well, again, I think we can go back to the biomarkers. So typically they look at both cognitive data, but actually there's been as I mentioned a huge emphasis on biological criteria. And the couple of clinical trials that are in phase 3 that I am familiar with, currently all of them actually use specifically amyloid and tau PET to monitor patient outcome. In fact, for example, in the aducanumab trials, they started only, initially it was only amyloid PET. So they were looking at, and this is a monoclonal antibody targeting amyloid. So they were looking only in addition to the cognitive scores, they were looking at, improved or decreased uptake on the amyloid PET scans. But actually, as the trials went on and as the tau PET tracers were developed, they slowly introduced tau PET. So in the end, they were actually using, decreased uptake on tau PET in addition to decreased uptake on amyloid PET to monitor their outcomes. So I really think that in the past couple of years, very firmly, both amyloid and tau PET have been used. And again, a lot of these clinical trials use both, not many really rely on plasma, but a lot of them do then, especially the ones sponsored by biopharma, use both CSF and PET biomarkers to monitor outcome or successful outcome.
Thank you. This is super helpful. I understand that you do a lot of joint reads for the PET and MRI in your clinical practice for neurodegenerative disorders. How do you do 2 reports, 1 report? Can you describe your clinical workflow for this for these complex disorders?
And I can actually, I guess I was very fortunate to be, to train at NYU and then be a faculty at Stony Brook for a year. And I bring that up because both institutions have had a PET MRI since 2013. So they were one of the earliest in the country. And perhaps more interestingly, they both had a very robust emphasis on clinical PET MRI. So, different institutions have different kind of a situation with these reads. And they also vary between brain and whole body PET MRI. So at NYU, actually, initially when I was a resident, they started as joint reads between nuclear medicine and neuroradiology, but with kind of a single, joint report. And then it slowly transitioned to one of the neuroradiologists. Actually, Mariam knows him quite well. Tim Shepard slowly kind of took over the dementia part of the PET MRI. So he reads both the nuclear and the radiologic portions of the report, whereas the whole body studies are still read jointly between the body imaging section and the nuclear medicine section. Meanwhile, at Stony Brook, when I was there, I used to read, both parts of the brain PET MRIs, but again, whole body imaging was very firmly read as a joint read between body and nuclear medicine. And then now at Northwell, slowly as I've kind of settled in, I've taken over the brain PET. So again, for the brain, I take care of both sides of the report. But again, I think it's because I almost had optimal timing. I started residency in 2013 when the first clinical PET scanners were introduced. So I was exposed, from my day one of training, and so I'm quite comfortable with that. But certainly, when there's a question, I always reach out to my nuclear medicine colleagues as needed. So I think, a collaborative effort is always brings a lot to the table. Sometimes with busy clinical schedules, that's not always feasible, but I think that's one of the real benefits of such a hybrid modality as PET MRI, that it really kind of, fosters and develops these interdepartmental relationships. And I hope you guys kind of are able to, recognize and enjoy that as well.
Thank you. Yeah, we're very lucky. Our nuclear medicine section and all the other sections are incredibly collaborative with each other. So
it's going to be fun.
I know. As we enter this, it's going to be interesting. I did want to ask another question for you. How do you approach the reimbursement issues for amyloid PET tracers? Because after the trials were done, those orders kind of like disappeared because it's just so hard to get it reimbursed. How are you guys doing that at Northwell?
Not well is the answer, is the honest answer. I mean, we are really giddy with excitement about IDEAS 2, since we scanned about 165 patients as part of IDEAS 1, and they were almost kind of daily in clinical practice. I know at NYU and at Stony Brook, it was the same. And now it's a trickle. It's been literally a couple of times per year. I think, two things to keep in mind is that the actual ideas results, especially, these effects on patient management and changes in diagnosis are relatively recent. So, we're hoping that CMS is kind of just biding its time. But I think more importantly for us as imagers, why on a quote unquote selfish note, we're so excited about this aducanumab PDUFA date in June is that when you think about it, if this amyloid targeting agent is FDA approved, all of the patients who are potential candidates will need to have documented beta amyloid pathology. And I really think that once a disease modifying drug is a reality in clinical practice, I don't think we will be having this conversation about, reimbursement anymore. And so I really think we're kind of almost there. Not quite yet, but I'm very hopeful, and I really think that in 2 to 3 years, it's going to be a whole different conversation.
Yeah, this is true. One of my colleagues here, Dr. Ahmed Mahajan, is saying, "Great talk indeed." He's really impressed, and he was asking which ones do get reimbursed, yeah, it's.
None. It's interesting. One of our actually mutual friends, Yana Ivanija at Cornell, she's also a neuronukes person. I think they have a little bit of a wealthier patient population, so she has these not uncommonly, maybe once a month, but her patients, are willing to pay out of pocket. For me, it's almost once a year, unfortunately. So nothing for now. Same situation with ABDOPA. Actually, the patients that we are able to push through are kind of paid for through some of the research studies and funded trials. So we have the same problem with ABDOPA, and Tau at this point, even though Tauvid is FDA approved, I have not scanned a clinical patient yet. All of the Tau subjects, both fluorotaucipir and PI 2620, have been research only. So I think we're all kind of sitting at the edges of our chairs and just waiting for some of these phase 3 candidates to make it to the market, so we can really kind of see this clinically as well, because that's the bottom line. We all want to help our patients, and so again, hopefully we all need to be patient just a little while longer.
Fantastic. And I have one last question, and that's about ABDOPA. Are you guys planning to be able to sell ABDOPA to other institutions, or do you guys have a cyclotron that you can use for your clinical use?
Yes, so we are fortunate enough that we have an on-site cyclotron, so that is quite helpful. But in terms of actually, supplying others, there's this contract with Cardinal Health. Now the legalities and kind of the contracts are a little bit over my head. I haven't been following as closely, but I think the bottom line, since I've been asked, I guess by you, but also by Cornell, by Stony Brook, when can we try this ABDOPA out a little bit? I think one of the major obstacles, again, we all come down to, we're just waiting for the CMS approval. And initially, since I'm not, I'm more neuroradiology, I don't read the DAT scans daily. I was like, oh, so, why is this ABDOPA so superior, or why would it potentially be better than a DAT scan? And then finally, I had one patient that had a DAT scan and the ABDOPA PET, and a picture is worth 1,000 words.
Wow.
Once you see, where is it? Here it is. I mean, once you see this quality and what you're able to provide, especially, and of course, if a patient is, strongly positive or strongly negative, it doesn't matter, but there's always that, 5 to 10% of scans when you're just not sure. So having this improved resolution, is really a game changer in difficult cases.
Well, thank you so much. We're so grateful to you for your wonderful presentation. And thank you so much for joining us.
It was my pleasure. And, I hope to be back soon, hopefully in person next time.
Yes, for sure. I'm excited to continue working with you.
Wonderful. Thank you so much.
Thank you.
Bye.